Good evening, everyone. A very warm welcome to all of you joining us here for this special World COPD Day session organized by Voice of Healthcare. I'm Dr. Muskan Elawat, and today's discussion theme is Short of Breath, Think COPD. It is a privilege to have this important conversation underlying the rising burden of COPD and the urgent need for early recognition and timely intervention. Chronic obstructive pulmonary disease is not just a respiratory illness, it is a long term progressive condition that gradually limits a person's ability to breathe. What makes COPD particularly dangerous is that it develops quietly over years. Many people mistake early symptoms such as chronic cough, breathlessness during routine activities, or frequent chest infections as minor issues. But in reality, these are the warning signs of a disease that damages lung tissue over time. Adding to the challenge, it is the widespread lack of awareness. COPD is often confused with asthma, seasonal flu, or simple fatigue, causing delays in seeking medical attention. In India, this delay is compounded by environmental factors such as high pollution levels, tobacco use, and exposure to biomass fuels for cooking and occupational hazards. As a result, India today carries one of the world's highest COPD burdens with millions affected, and many of them are undiagnosed. Yet, the hopeful part is that COPD is preventable and manageable, and if it is detected early, patients can maintain a good quality of life with the right care and treatment. So, today's conversation, our goal is to bring clarity, create awareness, and highlight practical tools and strategies for early detection, accurate diagnosis, and management. We are truly honored to have exceptional panelists and experts with us today. We have Dr. Piyush Goel, Senior Consultant, Pulmonary and Critical Care from Narayana Superspeciality Hospital, Gurugram. Welcome, sir.
Yeah, thank you. Thank you for appreciation. Thank
We have Dr. Vikas Mittal, Director, Department of Pulmonology, CK Birla Hospital, Delhi. I think sir will be joining in a while. We have Dr. Miti Shah, Consultant, Pulmonary and Critical Care, Chest Clinic from Mumbai.
Thank you, ma'am. Thank you for your introduction.
We have Ms. Nandita Dandekar, Director, Pink Tree Health from Mumbai.
Thank you, Dr. Muskan. Hello, everyone.
And we have Dr. Mayank Kapoor, Consultant, Pulmonology, Paras Health, Gurgaon.
Yeah, hello everyone.
We are very grateful to each one of you for taking your time to join us here today. So, starting with the very basic discussion, I'll start with Dr. Piyush. Can you
you.
explain what
Ji, yeah.
exactly is COPD and how does it differ from other respiratory illness such as asthma or flu?
Yeah. So, can you hear me now? Yeah. Are
Yes,
you hearing me?
yes,
Yeah.
yes, sir.
So, if you know, what is COPD basically? As the name suggested, that it is basically a chronic obstructive pulmonary or a lung disease. So, chronic means the disease which is there for long, and obstruction means there is some obstruction of the airways, or there is a blockage of the airways in the lungs, basically. So, as you say so in your initial introduction, also, that it is a disease which is very slowly progressing, and many of the times these patients are not able to know when this disease sets in their body, and we are able to diagnose this disease when already the damage is done. And most of the times we are able to diagnose this disease after the age of 50-55 years. But if you are a smoker, if you are living in a high polluted environment, and if you have some occupational exposures, then your disease is setting in your body very initial stages. So basically what's happening is, with prolonged or chronic exposure to all these things, your airways are getting exposed to these toxins, which causes chronic airway inflammation, and also the destruction of your alveoli, which is leading to common airway bottling with time, and leading to progressive airway obstruction with time. So this is COPD. So Now, the other question is how it is different from bronchitis and asthma, as the symptoms suggest. So, the most important thing to differentiate between asthma, bronchitis, and COPD is basically a history of the patient. So, if you are allergic to something, this means you can have asthma. But if you are not allergic, but still you are exposed to chronic uh, exposure to the toxins and pollutants, you can get COPD in the long run. So asthmatics have a history of allergies. This is their childhood, and also asthma is a episodic thing. COPD is a progressive disease. Asthma is not a progressive disease. Also, there are some good days, some bad days in asthma patients, but in COPD patients, it is a chronic airway obstruction.
I think Dr. Piyush just dropped off because of some network issue. So, Dr. Miti, would you like to continue that how it is different from other respiratory illness?
COPD is basically because of the chronic exposures that are there, and it is more of a disease which over time causes remodeling of the airways and narrowing of the airways, spasm of the airways, and it is kind of irreversible. It is always better to have an asthma where the disease is reversible to a great extent with good physiotherapy, avoiding the exposures in the future, and taking care of the airways. But COPD, once it is developed, the physiotherapy, the medicines, they are only helping the patient not getting worse and being able to cope with the day-to-day life if the COPD is very severe. Dr. Goel, you can take over, sir.
And sorry for this. So, as so she is right in saying that asthma is not a progressive disease, and but in COPD it is a progressive disease. So it is like a heartbreaking disease actually. If we are able to diagnose it in a proper way, we are able to diagnose it. So in India, basically the problem is through diagnosis. Diagnosis is a challenge right now. There are medications which can control COPD symptoms as a whole. There are treatments around which make patients' life disease free in COPD patients. But the challenge is to diagnose. And if you see, asthma can happen at in any age group. It can happen in children. It can happen in old age also. It can happen in middle age also. And it is asthma is basically a is it is basically preventable, and it is also a controllable disease, has some hereditary component associated with it. But in COPD there is no need of any hereditary component, and it is all because of your lifestyle habits and other things.
Thank you so much, Dr. Piyush, for explaining that so descriptively. So, we have Dr. Vikas here joining with us. Welcome, sir.
हाँ जी, yeah, thank you, Muskan. Yeah, tell me.
So, sir,
I
my
just
question
joined.
to you,
हाँ
yes,
जी.
sir, yes, sir. So, my question to you would be that, as a pulmonologist, how would you say that what is the burden of COPD in India and why it is becoming, such an emerging public health issue nowadays?
So basically, COPD is actually increasing every year, and now it's almost second most common cause of death in India, above, just next to the heart diseases. And 30%, 32% of the global deaths because of COPD occur in India, and it is actually every year worsening, and in the prevalence of COPD is worsening because of the increase in the number of smokers. And in India, because COPD not only happens because of the tobacco smoke, but it also happens because of the occupational exposure, as well as the use of biomass as a fuel in rural and semi-urban areas. So this, along with it, in urban areas there is a lot of pollution, and so all these things. And then another thing in India is we have a lot of chronic diseases, chronic infectious diseases like tuberculosis, which actually also as a cause of COPD. And with these three factors being there, increase in smoking, increase in pollution, increase in the burden of biomass fuel exposure in India. So, and this infectious disease, so this is actually making the COPD numbers increase and increasing the burden of COPD in India. So, so they definitely COPD numbers are all on the rise.
Thank you so much, Dr. Vikas, for answering and letting us know that how COPD is growing. So moving onwards, my question, next question would be to Dr. Shah. That as Dr. Vikas was also mentioning, can you let us know that what are the primary etiological factors that are contributing to COPD?
Yes, Dr. Vikas already mentioned, 90% of my answer, that 80 to 90% of the COPD is a combination of, tobacco, cigarette smoking, and indoor biomass fuel exposure, which is so common still in India in the rural areas and the semi-urban areas. And over and above that, any insult to the lung, may it be because of pollution, may it be because of some chronic respiratory infections like childhood tuberculosis, due to some occupational exposures, all of this can cause COPD in the long run. And even when a patient, even in a OPD, small OPD setting, at a GP level, or at a any healthcare giver level, like a physiotherapist, who has, for a patient, especially a male patient or maybe even female, age of 46 to 60 years, having late start of respiratory diseases, a good history will help us find the etiological factor and help us understand what the patient is suffering from.
So, ma'am, as you were mentioning about male and female, is there any prevalence that it occurs more in male or females?
No, not like that. I'm not sure about the exact numbers, but just because cigarette smoking is more common in the male, while biomass fuel exposure is more common in the females, so it is more or less equivalent, but there is no such proper figure to it.
Thank you so much, Dr. Miti, for explaining that. Moving onwards to Ms. Nandita, that we would like to know from you that from a community and a patient support perspective, how can awareness and education, at the grassroots level help us better identification or better management of COPD?
Sure, Dr. Muskan. So, thank you for that question. We have been doing some work at the community level, and particularly we have worked in the slums of Mumbai and in certain parts of Maharashtra. And one thing that we have realized is that it's really heartbreaking to know that patients or general people don't really, even acknowledge their sufferings. They accept COPD as a part and parcel of their life. Many times they don't even know they have COPD. They only say that, oh, I've been coughing for, quite a few months, or, they even are not able to climb up the stairs of their own home, and they adapt to that particular lifestyle. So I think awareness becomes absolutely critical. And that's why whenever we are doing community camps in Pinktree, we club awareness with action, because I think it's also important to make them realize that how this is impacting, if the AQI of the city is bad, it's important to know how that is impacting your lungs. And that's why we have tools that, kind of screen patients and tell them if they have a lung issue. So I think community level awareness becomes absolutely critical for people to know. Like doctor was mentioning that, women, a lot of women, are exposed to biomass fuel. How many of them really know that? And they have their small children's running around in the place. So even the children get exposed to this, and they don't really understand the impact that is having on their lungs. So it becomes very, very critical.
Correct. I agree, ma'am. I think, frontline awareness can really change the progressiveness of this disease. Thank you so much for answering that. So moving ahead Dr. Mayank Kapoor, we would like to know that, there are some early symptoms that are often overlooked. So how can primary, physicians or clinicians can recognize COPD at early stages? So you are on mute.
Okay. So most common what I have seen in these kind of patients is that shortness of breath on exertion. Whenever they're doing any kind of work or they're climbing a flight of stairs, if they experience shortness of breath and there is a history of smoking, the first and foremost and the earliest symptom is shortness of breath. Along with that, cough with expectoration, or what we call it as chronic bronchitis. People who are smoking, they will always be having cough and they'll be always be spitting phlegm here and there. So if the patient is having these initial two symptoms, I think he has to get himself checked from a pulmonologist and get the required tests done. And first and foremost is try to stop smoking or any other biomass fuel exposure. That's the best thing to do. And if the patient is having these symptoms, he should, try to avoid all these things.
Correct. Thank you, sir, for highlighting about symptoms and when one should consider visiting to a doctor. So, as we have just laid the foundation for COPD. Moving onwards, we would like to know from all of you some diagnostic tools or advancements that have been here. So, Dr. Goel, my next question to you is
Yeah.
that there are some diagnostic tools that are better here as for primary care across India for COPD.
Yeah, so the most important, the gold standard test for diagnosing COPD is a pulmonary function test, that is lung function test. It is a non-invasive test. No blood is required for this test. It's a very simple test. Any patient can do it. Any person can explain to a patient that how to do it. Little training is required, nothing else. And to nowadays there are portable equipments for doing pulmonary function test, and also the cost of this test is also very low nowadays. Previously they are very heavy machines which are available only in big setups. Now there are portable machines and we can go to each and every peripheral center with that machine, and there are pocket machines also, and it's a very simple and non-invasive test. Only thing is little training is needed who is doing the test, and it's a very simple training, and we can give training to many people. And a 1 day or 2 day training is I think it's sufficient to learn how to do a PFT.
So, is there only one test or any other test that are,
So this is the gold standard test. So we can do screening pulmonary function test or a spirometry. We can call it as spirometry also. So we can do screening spirometry at the community level to diagnose the prevalence of this disease. The number one. Number two, there are associated tests which we can do. For example, we can see some findings in chest X-ray. Number three, we can diagnose these type of patients with some experience with a history also. And many of the cases there is no need to do PFT also, but you have to realize to your patient also that you definitely have this condition, then the test is required. So X-ray is helpful, the PFT is gold standard as I told you. Another is nothing else, I guess. COPD, for a COPD, CT chest and other things, you don't require those things. X-ray and pulmonary function test are the very basic and the cheapest and the best way to diagnose COPD right now.
thank you, sir, for highlighting the two best diagnostic tests that are
Yes.
available for us. So, moving
Yeah.
onwards, Dr. Vikas, as Dr. Piyush was mentioning about diagnostic tests, so what are the key challenges that clinicians see in ensuring accurate COPD diagnosis, and they avoid underreporting for them?
See, as Dr. Piyush said, COPD can only be diagnosed if you have an obstruction seen on a lung function test, which is also called pulmonary function test, PFT, or it's also called a spirometry. So, and so the thing is, the first thing which actually makes this difficult to diagnose COPD is a lack of availability of a good spirometry. So spirometry is like I sit in Delhi, so we see PFTs being done we get PFTs done from labs, which I think 99% of them are wrongly done.
Yes.
because these are done by a technician who is mainly a basically who is multitasking between an ECG, echo, PFT, and TMTs, and also these technicians are not trained to do a PFT. And the PFTs, then second is the PFTs which are done are like not properly done and neither reported. Somehow I
Yeah.
see it very unfortunate that the many of the test even comes without a signature, and sometimes the signatures are just done without seeing the report by any physician or a pulmonologist, sometimes rarely. So good quality PFT is the word, because PFT, if not done properly, it's actually a little technical test, not a difficult test, but a technical test, and requires a little training once by a pulmonologist or by somebody, and a quality control of that PFT should be done. So there should be a calibration. If it is volume based, or if it is not ultrasonic, then it requires calibration. So we need to really know which machine, which place, which
Mm.
technician is doing the test, so that we get a proper PFT. Second challenge which I see, which makes the diagnosis of COPD difficult, is lack of awareness. See, many physicians even don't know that COPD is a PFT diagnosis. You can never label a patient as COPD without a PFT. So sometimes loosely the physicians label people as COPD, and just based on the history, and like many long-standing asthma patients are labeled as COPD. Anybody with long-standing breathlessness, whether it is because of any other disease, like there could be a heart disease, or it could be a chest wall abnormality, or an interstitial lung disease. So these patients are all labeled as COPD in general. And asthma is a clinical diagnosis. Most of the time you have to demonstrate variability in symptoms and tests, but COPD is only and only PFT diagnosis. So lack of awareness among physicians, and then public also. Third is public. So public also doesn't know COPD. Everybody knows about asthma, and for them every shortness of breath, long standing
It's
shortness
awesome.
of breath, is asthma. When mane dama usko, they always say either dama or asthma. So for anybody, breathlessness means asthma, whether it is because of COPD, ILD, lung cancer, or any chronic disease. For them, long standing breathlessness is this asthma. And then the thirdly is whenever the breathlessness strikes in a smoker. Okay, so and we see a lot of patients even first going to a cardiologist, getting their stenting done and all, and even there the COPD is missed. So lack of awareness among physicians, even the super specialists, also is a major concern which I see. Then the another concern which I see is lack of awareness about the causes of COPD, because see, people think that only smoking is the cause for COPD. People forget that COPD can be because of chronic lung infection like tuberculosis, damaging the airways, or any like even some kind of like, and all these people, like we are sitting in Delhi NCR, which is one of the most polluted cities of the world. So we will see in future, we will see people having obstruction in their airways, as pollution is now listed as a etiology and cause of COPD. So as we have a long standing exposure of around 10-20 years, then we will see lung function abnormalities. So people should be little more aware of getting your lung function test, and a good lung function test should be really available. So good pulmonary function test, awareness at physician and the patient level, and recognizing the difference between COPD and other chronic lung diseases is important to make a proper diagnosis about COPD, so that we can pick it up properly.
Thank you, sir, for letting us know the interlinkage and the training that is necessary for PFT and the technician who is doing the test. So, moving onwards, we would like to know some of the tools or some treatments that are available nowadays. So, Dr. Shah, can you highlight, any treatment plans or, self management that patients or individuals can do at home, or they can better control themselves for COPD?
Sure, ma'am. So once we take the history and once we do a spirometry test and we diagnose the COPD, and based on the severity of the spirometry, the COPD is graded. And we have to, in India, the first step starts at convincing the patient to take the right inhaler. Okay, they are a major population is just having a stigma or a taboo with taking inhalers. So yeah, our first job is to convince the patient that at least start taking the inhaler. We in fact have to sometimes I dispense inhalers from my clinic so that at least they take it. Otherwise, patients even avoid taking the inhalers even after writing it on their prescriptions. Once we prescribe the inhaler, it doesn't stop at that. We have to explain them the correct technique of taking the inhaler, because just taking an inhaler somehow, because there are these newer advances, there are multi-meter dose inhalers, there are dry powdered inhalers, there are breath actuated inhalers, there are a variety of inhalers which are available, from once a day dosing to thrice a day dosing. So we have to exactly explain the patient how to take it, and even explain that based on their severity they may be given tablets along with it, they may be given nebulization as and when required, but inhalers form the mainstay of their therapy. This has to go into their minds, and actually when they start using it, they feel the difference, doing day to day activities like even going to the washroom, having taking a shower or climbing a flight of stairs becomes much better for them, which they couldn't do for so many years. So actually the whole stigma that they get habituated to it, we tell them that you should get habituated to it, not avoid being habituated. And this is the segment of people, the severe COPDs, who actually get not really habituated but who actually really need the inhalers, not the mild asthmatic. So giving the right inhalers, that forms 50% of their management. The another 50% is taken care by a couple of things, and breathing techniques, breathing exercises forms the mainstay of therapy. There are various programs available by various pharma companies, and there are pulmonary physiotherapists specially there to guide and train the patients if they can do it at home. Or there are pulmonary rehab packages or programs which are scheduled 3 times a week, for 2 to 6 months. They can actually go to the physio. It will, they will feel okay, it is just simple breathing. But just how going to the gym changes a person's life. If a person goes for 6 months continuously, their body gets trained to do everything at a better pace. They get more, much more stronger. Same way their breathing muscles get habituated, their breathlessness reduces, they know how to focus on inspiration, expiration, and all those things. So pulmonary rehab forms a very important part of the management, almost maybe equivalent to medications, to give them a better quality of life, to reduce their morbidity from the disease. Of course, other than that, managing all the comorbidities associated with disease, like muscle wasting is there, or depression is there, social stigma is there. All those small aspects also should be managed and seen and look forward to. Good nutrition, good protein based diet, good vitamin rich, green leafy vegetable rich, fruit rich, basically a good healthy diet is also what should be emphasized on. Because by the time the patients have reached us, the COPD patients, most of them are really weak, really frail. They don't even have any muscle mass left to work out, or to basically do their day to day activities. So it's an entire spectrum. And people ask us, like a person from the upper middle class or the higher community will ask us how to improve your lung immunity.
Correct.
There's nothing, there are no tablets or no supplements for lung immunity. Lung immunity is basically a combination of the right food, the right exercise, the right medications, and being in the right environment. So same way, improving your COPD starts with the inhalers, starts with the tablets if required, SOS nebulization, good physiotherapy, and vaccination for flu and pneumococcal disease, so that an already weak lung, which is at 70, like anywhere between less than 80% to even 20%, 10%, also doesn't get further insults by diseases, and they maintain or improve their capacities.
Correct. So, ma'am, as you were, I have a generic doubt that as you were mentioning about immunity tablets, we kind of have, immunity teas or, specific teas that are, public worldwide for immunity and good lung health. So, are they effective or they are just, in market for myths?
I think they are just in the market. They have some of the other antioxidants in them, which may help their breathing and lung health to a certain extent. Even people say lung detox. There is nothing like
Right.
lung detox in terms of taking something or taking something in or out. It's just breathing better, improving your breathing techniques, and good nutrition is what will cause detox of the lungs. The immunity pills or tablets may definitely not harm, but just taking them is not going to help them.
Correct. Thank you so much, ma'am, for answering that. So moving onwards, Dr. Mayank, from a policy and a public health perspectives, and as a pulmonologist, how would you know say to your patient that awareness, diagnosis, and timely intervention is important for COPD? So you are on mute.
There is a patient who, especially the female patients, when they come to me, I tell them that, if you're doing a puja and you're lighting your agarbatis and dhoops, so these are the main cause of indoor pollution, and these also damage your lungs. So they go into astonishment whether, this, how can this cause? How can my spirituality cause indoor pollution, other things? But that is the reality. So many of the urban living population, they don't know about the indoor pollution. They only know about the outdoor pollution. So it is very important to in educating these population regarding what is an indoor pollution, how normal day-to-day things what we do can lead to an indoor pollution, and how can they harm our lungs. And of course, the government of India is always, planning whenever we see a cigarette packet or anybody who is smoking, or whether it's a big screen or a TV, they have started to write "Stop smoking" and injurious to health. And they should also put a fine everywhere those people are smoking in a public places. So I think many of these factors and prevention of showing that smoking is cool, and people who smoke, they are people can go to high places those who smoke. But in reality, by the time they turn 60 to 65, they are hospitalized, they are bedridden, they are having shortness of breath. So it is, very essential to educate the urban population regarding the harmful effects of both indoor pollution as well as the outdoor pollution.
Correct. So rightly said. I think the newer generation is, very fantasized about alcohol and smoking, and they are just doing it
Yes.
very casually. So, sir, can you highlight also some preventive strategies that one should follow for COPD or for lung disease?
As prevention strategies, the best thing is to stop smoking. That's the number one and foremost rule. If the patient is smoking and patient is having any symptoms, stop smoking. Stop any kind of exposure to the smoke, whether it be an active smoke or a passive smoke. So the number one foremost is that. Secondly, take your inhalers if you're having a symptoms regularly. Vaccinate yourself because your lungs are weak, so it is better to go in for an adult vaccination schedule, and try to do some pranayam, yoga, and prefer a high protein diet because obviously patient of COPD is having a very slender body, a cylindrical type of chest. So a high protein diet will also help in making his muscular building. So all these factors, help the patient into prevention of any further lung damage and because of any infection, and also in the COPD.
Correct. Dr. Vikas, would you like to add something as you were mentioning about AQI of Delhi? It is increasing day by day. So, any preventive strategies that we should follow for that?
Yeah, so basically, since pollution is going to stay with us till a major public initiative is taken by the governments and the organizations, so we really need to protect ourselves at individual level. So first and foremost, we should really keep a track on the air quality index, and if it is bad, like obviously it is bad most of the time of the year in Delhi. So you should avoid going out in early morning and late night hours when the pollution is at the max, and at the same time during these early morning and late night hours you should avoid ventilating your house by opening the doors and windows, which is a usual tendency that the people open their doors and windows in the morning so that the fresh air to get in. But in the morning and evening hours, the air is not fresh; it is full of pollution. So the best time to open and ventilate your home is by putting the windows and windows open only during in afternoon when the sun is there, and maybe you can put on the exhaust. Second is, if you try to stay indoors and follow the AQI, because during the high AQI you should not be doing any physical activity outside. So you should try to stay indoors, especially those who have already a COPD. So they should actually, and also try to keep your indoor environment better by decreasing the indoor pollution, by decreasing the fumes in the kitchen, and by using a chimney, and obviously avoid biomass fuel exposure. Then the incense sticks, the oil lamps, so all these things we should avoid so that the increase in the indoor air pollution is not there. Then this second then you should actually, if you can afford, and those who are having like severe COPD and they are like usually confined to a room, then they can consider keeping a good air purifier with a good air filtration rate and a HEPA filter, so that it filters out all the PM 2.5 and all. And it should be kept on most of the times with the doors and windows closed in that room, and especially while you sleep. And maybe if you want to keep it in one room, then it should be your bedroom. Then there's no role of indoor plants actually, because you need thousands of plants to keep that level of air purity. And last but not least, to cater to the pollution, you should uh, like take care of your own health by taking regularly your inhalers and regular medication, and check with your doctor even when you are well. And last but not least, take care of your sleep, nutrition, hydration, and exercise and stress. So these are five things which I always tell my patients. If you take care of these five things, then you will not fall sick, even in spite of the worst of pollution, which we cannot really change much the situation.
Correct. Thank you so much, sir, for highlighting all those points that people should follow this season, as we have so much of pollution this time. So moving onwards, we have been seeing that technology is at boost, digital health is at boost. So, Miss Nandita, how role can digital health or telemedicine can play in follow-up care, or ensuring the adherence of treatment plans?
Sure. So we are actually just back from a national pulmonology conference that happened in Jaipur. And we had hosted a session where we actually invited patients and doctors. And one of the things that really came out strongly was that doctors said, and I'm sure the panelists along with me will agree, that doctors are not able to spend a lot of time, more than 10 or 15 minutes per patient, because of the patient load that they have. And patients, they really expect more time. They want that somebody should listen, their doctor should listen to them. And this is a constant struggle that doctors want to cater to their patients, but they don't have that much time. And I think that's where the role of digital platforms and digital technology comes in, which becomes like an extended care support for the doctor to extend to his patients. So it's from the doctor's side that this digital platform can actually onboard patients and can offer all the support that the patient needs, maybe between the two consultation visits, because typically these patients will come to the doctor within a gap of 3 to 6 months, and that is the time where technology can play a part. It can be that linkage between the doctor and the patient. And like Dr. Miti Shah mentioned, there are so many things that the patient needs to take care, and the doctor is also constantly thinking whether my patient has taken the vaccine, has he taken the inhaler properly, has he been doing his walks regularly? Has he been doing yoga regularly? Now imagine a platform that can actually do that and also keep the doctor updated about how his patients are doing. And obviously the doctor doesn't have the time to look at all his patients, but if he's even monitoring his critical patients, or those patients who he feels that needs his attention all the time, while say Dr. Miti is traveling from her resident to her clinic, she opens the platform, looks at her patients, and she feels that this particular patient needs attention. She has that data to actually, call up the patient to say that I think there is some issue. You need to, visit me in the clinic. So I think patient generated health data, as we call it, is becoming increasingly important, and I think digital tech can actually provide that to doctors. Thank
Thank
you.
you so much, ma'am, for answering that, very descriptively, that how digital health is evolving and how patients require the time. And I think it is more of a multidisciplinary approach. Even psychology or pulmonologists, they help. Dr. Miti, I would like to ask a question that talking about multidisciplinary collaboration. How is it helpful that pulmonologist, general physician, or physiotherapist would they help improve COPD outcomes altogether?
Yeah. Yes, definitely. First they have to come to us as pulmonologists, start the primary treatment that they have been advised, and ideally in a city like Mumbai, we don't have the space, to have a physiotherapy room in each and every clinic. But if it is a part and parcel of the clinic, nothing like it. A physiotherapist can, as I mentioned earlier, have an equally strong hand in taking care of the morbidity of the disease and overall rehabilitation of the patient from what they were and what they can actually become in the long run. So yes, even a good nutritionist, a good physician will help in improving all their other aspects of the disease, and a joint collaborative role can really help in improving the health of the patient.
Thank you so much, ma'am, for highlighting, how it is important that all of us together work for COPD. I have one more question for Dr. Piyush.
Yeah.
Sir, are there any most common triggers for, acute exacerbations of COPD or uh, any lung disease like asthma or seasonal flu?
So the if we talk about COPD and asthma, the most
Hmm.
important thing is, if you are asthmatic or a COPD patient, kindly continue your medication as prescribed by your physician. Many of the times, people used to stop their medication of own, as now they are feeling well, so they suddenly stop their medication, and suddenly there is some trigger in an environment. For example, any cold air is blowing outside, or any pollution levels are rising, or there is a change of season, so they suddenly got the symptoms got worsened up. So we always advise people not to stop medication of your own. And these are all diseases, as you are taking medications for asthma and sorry, for diabetes and hypertension, similarly you should take medication for asthma and COPD also on a regular basis. Secondly, the vaccination is a very important thing. So if people used to take adult vaccinations like pneumococcal or a flu vaccination, then the trigger of getting we can reduce the trigger of getting asthma attacks or COPD attacks in a very drastic manner. So vaccination is also very important to these people. Thirdly, if there is air pollution outside, if AQI is an issue right now, so kindly wear face masks. So face mask is advisable to each and every patient of COPD. Similarly, as you told about flu patients, flu diseases which are going on, which the prevalence is high in this particular time of season. So vaccination is the best thing to get right now. And if you are allergic, if you are asthmatic, if you are having a COPD, so you can get a severe attack of flu also. So vaccination is important, face mask is important, and regular a visit to a pulmonologist to get checked. And regular intake of medication is important, so we can avoid getting triggers of this disease.
Correct. Thank you so much, Dr. Piyush, for breaking it so easily and how I think definitely the audience would follow all the points that you mentioned. So now, concluding to the discussion,
Yes.
I would ask, any message that you would like to convey on today, World COPD Day, to the audience. So we'll start with Dr. Miti.
Uh, just remove it as a stigma, everybody. Just think of it as a disease, understand the disease, get more aware about what is COPD, and that itself will solve half the problem. And listen to your doctor and don't be
Hmm.
worried of anything else.
Dr. Vikas, what would you like to convey to the
I
patients
think
or the audience?
yeah, so the message is this tagline, short of breath, think COPD is a very appropriate message. And this is the same message I would like to give is like when you are breathless, you should think of COPD. Every of asthma, you should really think of COPD because it's really a highly misdiagnosis and neglected disease.
Correct. Dr. Mank, would you like to say something?
Yes, in one the world stupid, I just want to say that inhalers is your best friend. Don't think of your inhalers as a stigma. Many people just say that we can't use inhaler in public places. What will other people think? But if you use inhalers, you won't require any other medications for a long time, and just think of it as your friends.
Sure. Miss Nandita, would you like to add something?
Yeah, sure. So breathing, which each one of us does 20,000 times in a day, is actually a struggle for some people who are suffering with COPD. So take care of your lungs, and I think it's a right to breathe clean air. So speak up for COPD and make this place a better place to live. Thank you.
Correct. Lastly, Dr. Piyush, would you like to, give a message to the public and audience? I think sir just dropped off due to some network issue. That is fine. Thank you so much to all our esteemed panelists for sharing such meaningful insights today on World COPD Day and for giving us your time for this session.
Thank you,
Thank you,
Muskan.
Mr.
Thank
Thank
you,
Thank
you.
you,
and
Muskan.
we
Bye.
can
Thank you.
share a bit of awareness and improve the awareness.
Definitely,
Hmm.
ma'am. Thank you so much.
Thank
Thank
you.
you.